I'd like to welcome Dr. Mary Barrow from MedStar National Rehabilitation Hospital to present on the Transitions of Care Outcome Tool, identifying unmeasured metrics, reducing provider redundancy, and allocating limited resources. Take it away, Mary.
Thank you. Good morning. My name is Dr. Mary Barrow, and I'm here today to introduce you to a highly successful interdisciplinary pilot program and product implemented at the MedStar National Rehabilitation Hospital in collaboration with the University of Maryland School of Pharmacy, called the Transitions of Care Outcome Tool, or TOCAT. The goals of this product included promoting safe medication regimens. As pharmacists and pharmacy students, we completed a patient medication reconciliation to optimize drug therapy and provide patients with personalized medication discharge sheet, which I have an example of later in this presentation. We also developed a tracking tool which could be used to quantify the value of the pharmacist team involvement in the discharge process using the 10 TOCAT intervention categories. We also used this data collected to identify and improve safety opportunities. So we were able to produce a tool that could be used to improve patient safety culture and reduce redundancy. This tool is simple, innovative, and can be used to capture previously unmeasured metrics at discharge. The data collected can be analyzed for hospital improvement purposes. The adaptation of this tool is inexpensive, simple, and can be integrated into existing workflow processes. This project ran for a little over a year at MedStar Rehab Hospital. 210 patients qualified for inclusion in this study. On average, each of these patients had 7 medications at discharge and received 12 interventions documented by the pharmacist. We will discuss these interventions further in detail in a few moments. An IRB was also obtained from the MedStar Health Research. So this tool was implemented through the following process. If an eligible patient was due for an imminent discharge, they were an opportunity to use the TOCAT process and tool to improve outcomes. Then a complete med rec was completed by the pharmacist and a set of pharmacy students. If a medication discrepancy was discovered, a collaboration with the healthcare team was completed and the discrepancy was resolved. The pharmacy team would then create patient-specific education materials and complete a face-to-face medication safety and compliance education counseling session with the patient. The patient also had the opportunity at this time to ask any clinical questions to the pharmacy team. Afterwards, the TOCAT data from the patient education session was documented and evaluated. The metrics collected could determine trends in medication errors. This allowed for hospital improvement opportunities, such as education guidance sessions, grand round sessions with medical students and physicians, published journal articles, and corporate poster presentations. So here is a sample of a patient education handout. These handouts are customized for each patient based on the medications they were going home with at discharge. They included the medication name, what the medication was for, how it should be taken, and when it should be taken, including pictures to help easier explain. These handouts have been very positively received by patients of all healthcare literacy levels and patients who had language barriers as well. So here we have the 10 intervention categories previously mentioned, as seen in the first column of this table on the right. These tables are a little bit difficult to read in this PowerPoint format, but are easily readable on our poster. 55.7% of the pharmacist interventions were related to supporting medication compliance and side effect counseling. These interventions are preventative in nature and are often not captured in other evaluation tools. On the graph on the left, we can see that in the blue, the majority of the interventions performed by the pharmacy team are traditional pharmacist tasks, which is to be expected. However, surprisingly, over 20% of the interventions performed by the pharmacy team are actually traditionally tasks performed by the physician, and that is in the orange, which reduces the burden of these tasks being performed by the physician and therefore reduces redundancy in the workflow. Additionally, 5.8% of the interventions were interdisciplinary in nature and helped to improve cohesion of the healthcare team. So that is a brief overview of the TOCAT tool and its implementation and use at the MedStar Rehab Hospital. Please reach out with any questions you may have. Thank you for your time.
Thanks. I actually noticed that education handout with the images and simplified language actually looked really easy to understand. Do your pharmacists and folks doing the intervention use like a teach back method or anything else to make sure the patients understand?
You know, we do a in-person patient counseling session. We review it step by step, and then we ask for, and that's where some of the redundancy is removed. We answer every clinical question that they might have, so they don't have to call the doctor back. We handle any concerns that they have about, you know, nursing issues, not understanding the medications, delivery of the medication. So that's where we remove some of that redundancy from the interdisciplinary team. There is a teach back. We do make sure that they understand everything. We over at MedStar, NRH, we're in DC, we have a really high literacy and culture barrier when we do our medication education. So, and to have a sheet that's pictorial, so that if the person either doesn't read or is, you know, reads in another language, or maybe doesn't understand health literacy and understand medications normally, this sheet really helps them understand, when exactly do I take it? What is it for? The what is it for is actually one of the most valuable things on there, besides the pictures, because, you know, statistically we know that if a patient understands why they're taking a medication, they're going to be much more compliant on that medication. And many of our patients don't really know what the medication is or why they're on it. So yes, I guess the answer is yes, we do.
Yeah.
We do a teach back, but generally the sessions can be up to 20 minutes long, depending on if it's a long list of medications. So we remove that from the nurse and from the doctor, that counseling session. And then we're also willing to go to the physician if they say, you know, I'm wondering if I should be on this, I'm wondering about this medication, you know, should my other doctor know that? We can take that step and go to the team and bring it up, so the doctor doesn't have to come back to the room, the nurse doesn't have to come back to the room.
Right.
So it really does save time for everyone.
And developing a rapport to sort of help provide that feedback to the team as well, potentially.
Yeah.
That's great. Is the tool design where could we be used outside of the rehab setting? It looks like it might be.
Yeah, it's a universal tool. We actually started building it into the Cerner system. We use Cerner so that it could be used universally. Right now it's built, but it's not available. So people could actually use the Cerner system, record all the data, and it could be available for people to pull reports. In our pilot, we pulled the reports. We kept, you know, on a secure server, we kept our own data. But once it's built in and it goes into the, you know, the electronic health records, then anyone can pull reports on any of the data that we find out.